Hello, everyone. I'm very excited to have this session talking about the future of mental health treatments, specifically thinking about precision medicine perspectives. There's been a bit of a dearth of treatments within mental health, but we're finally starting seeing some evolution within new treatments, new approaches, and really bringing some of these new treatments that are really desperately needed for patients. Really excited today to really discuss some considerations about some of the historical struggles within mental health, ways moving forward, and what it means for patients moving forward. I'm honored to be joined by these two wonderful speakers, Johan Luthman and Sahil Kirpekar, who have done a lot of work within mental health in their careers, both professionally as well as by personal background and experience. So I'd love to start with a round of introduction. So I'm Varun Renjen. I'm a managing director in KPMG's healthcare and life sciences strategy practice, physician by training, strategy consulting, and do a lot of work within precision medicine and within neurology and mental health specifically. If we could have introductions, Johan, if you'd like to go first, please.
Yeah, thank you, Varun. So I'm Johan Luthman. I'm head of R&D at a neuroscience company, fully neuroscience-focused company, Lundbeck. We're headquartered in Denmark, and I've been there for 5 years, and I've been in the industry for many years, in many companies, small and big, the biggest in the world, and the probably smallest in the world I've been working for. So I have a pretty rich background, but neuroscience has been my heart and my soul for all my career. A little bit of stint in immunology and inflammation disorders. I have a background from the Karolinska Institute, clinical and preclinical sciences.
Wonderful. And my name is Sahil Kirpekar. I currently serve as the Chief Business Officer at a company called Atai Life Sciences, which specifically focuses on the treatment of mental health disorders. I'm a physician by training. For the last 17 plus years, I've been in life sciences across a range of roles, strategy, commercial, and business development. Before joining Atai at the end of 2022, I was in a much larger company, again, with a heavy neurosciences and psychiatry focus, Otsuka Pharmaceutical. And before that, I was working across a range of smaller and larger companies as well. My focus has been CNS, but also other areas such as immunology, oncology, and nephrology over the years, and excited about having this discussion across a range of modalities. Thank you.
Right. Wonderful. And I think what's nice here as well is that Otsuka and Lundbeck have also collaborated on quite a few different therapeutics that they have successfully brought to the market. So having this joint where there's this experience where everyone's worked together, I think is going to make this even a more fruitful discussion. So with that, we can go ahead and get started. And historically, we've seen a lot of therapeutics succeed in phase 2 and then unfortunately fail in phase 3. And that has been something we've seen again and again, not just in neurology, but really within mental health specifically. So Johan, thinking about that specifically, what has been historically the struggle in developing from mental health treatments from phase 2 to phase 3? Where have companies gone wrong, and what does that mean moving forward?
Yeah, there are many, many reasons, of course. One is the obvious one. We know very little about the diseases we're dealing with. The biology is not well understood, and I'm generalizing, of course, but if you look across the spectrum of psychiatric disorders, we have some hints what's going on, but basically not much known about the basic biology and pathophysiology. And we're often dealing with networks rather than specific molecular targets that are mutated or something like that. So that's the basic problem. And that leads to a number of downstream issues. And one very critical thing in R&D drug development is that you like to de-risk early. You like to have ways of reading out robustly when you test particularly new mechanism of action in patients. And that is often not possible in psychiatry because we don't have that biological biomarker, the readout we like to have. There are many, many attempts in this field, many imaging, functional biomarkers, whatever we've been using, but they don't really have that validation that we need to have to de-risk late development. So quite frankly, we've been running it quite traditionally with hopefully a decent phase 2 trial. And when that worked out, we went to phase 3. And that's where the replication problems are coming in. And that's very much also related to the nature of the diseases we're dealing with in terms of diagnostic precision, how we can subgroup patients, how we can really sort them out, because quite frankly, psychiatric diagnoses are phenotypic diagnoses, observation of people. They're not based on biology, they're based on the symptoms you present. And that's why we have quite crude ways of identifying patients. And you just take one example across the board, post-traumatic stress disorder. Many reasons why you have that condition. Childhood trauma, spousal abuse, war experience, car accidents, but we still call that one syndrome, sometimes even a disease, right? And that cannot have the same biological background. And the brain, of course, show different resistance and response to treatments. And then finally, so of course, we have pretty crappy, to be honest, outcome measures. It's again just asking people and caregivers how they feel. We need to make those more objective.
Mm-hmm. So to defer that, what I'm hearing is that these are incredibly heterogeneous patient populations. 2 patients with PTSD, 2 patients with depression will have different symptomologies and different biological considerations. And I think that biological consideration is an important one. I think people are starting to finally accept the fact that mental health is a biological disease. So as we think about that and that great understanding, Johan, furthering to that point, what does the future of mental health look like to you? Where do we move forward, and how do we bring more successful therapeutics to patients?
Yeah, it's quite interesting. We have seen kind of 2 avenues here. One is kind of the old way of doing it that occasionally is successful, meaning that targets that we actually been hammering on for many years, biological pathways that we've been exploring, they start to seem to deliver, and we start to be better and better in delivering upon those targets and biologies. We still don't really fully understand what we're doing, but we have better ways of reading out those drug effects. The other one I'm a little more pessimistic about, and that is going back to the biological understanding about the diseases. But there are certain diseases where we have much better grip on what's going on. And I think imaging is a strong tool here. Circuit pathway analysis is a strong tool here. So we have to be better at genotyping and phenotyping and whatever we do with patients. And I think here we have a great possibility with more objective measures. Having readouts that kind of take away the subjective reporting element. Take things like how many times you cook per week, or how many times you do hobbies, or how much you walk, or how much you exercise. These things can be measured a little bit in a more objective way. And I see some great examples of this in public healthcare. For example, in the UK, they're testing out now completely different ways to evaluate what kind of impact mental health treatments have. And I'm not talking about drugs here, I'm talking about all different kinds of treatments. And they really try to see how people are coming back into the society. And this classical real world evidence that we talk so much about actually has a big role in mental health. See also more objective ways of measuring things. Do we have the genetic cause of schizophrenia sorted out after 30 years of genetic studies? No, not at all. We're not there yet. But those diseases are developmental diseases. There are something fundamentally changed in the brains of those diseases, and tools are getting better and better to detect changes in those brains.
Mm-hmm. So to that point, and understanding biological considerations, and you touched upon phenotypic considerations, Sahil, I think of some of the big diseases, whether it be schizophrenia, PTSD, depression. What have been some of the key phenotypic findings, some of the key genotypic findings that you think we can start to leverage to use that to develop better therapeutics for patients moving forward?
Yeah, and it's a great question. I mean, as Johan mentioned, there's very little understanding, especially when you start looking at some of the physical aspects of disease and the biological basis of disease, and we continue to see gaps there. I mean, especially on the genotypic side, you can identify certain aspects, if there's syndromes that lead to autism, and then certain presentations as a result of that clearly is a basis, but that's a significant minority of what you see. phenotypic aspects, however, and specific, could be sort of race, gender, age combinations. There's been a fair bit of understanding of what leads to what prevalence in what patient groups over the years. However, that is not that's more diagnostic rather than treatment focused. When you start thinking about what treatments would be more relevant, that's where sort of more novel biomarkers have been considered, and that's where you would look at functional biomarkers, as was mentioned, but even digital biomarkers, which are sort of more novel, more unusual, and are sort of trying to translate symptomatic or behavioral aspects into more tangible phenotypic features that can be then used to segment patients out. A lot of this is in its early days, and we started seeing patient segmentation, which potentially could lead to better outcomes, better targeting for specific medicines. And there's early clinical trials ongoing right now, which should potentially present this. Until we see data that has treatment effect for sort of new ways of segmenting patients based on certain phenotypes, I think the jury's still out there on how relevant it is.
Mm-hmm. So that's only from a phenotypic consideration. And when I think about the whole treatment journey, certainly many patients present with symptomology, technically even years before they are initially diagnosed with whether it be PTSD or depression. Are there markers or biomarkers, whether it be functional, genotypic, phenotypic, or others that are being developed to really help with that initial upfront diagnostic? And then as patients get on treatment, are there biomarkers that could be theoretically leveraged to really think about how do we monitor patients for treatment changes to help give them the changes when they need it, the appropriate treatments at that time?
And you're touching on some very critical points here, Varun, because one of the challenges with psychiatry has been that diagnosis is crude. It's based on scales that test symptoms in the clinic over a very short period of time, and then try to sort of use that as a way of driving treatment. That treatment tends to be more of an art rather than a science. Most psychiatrists sort of like to play around with, moving around doses, and there's a lot of polypharmacy around. However, what technology has offered us as an option over the last years is the ability to look at patient data, things that you can collect from the patient passively or actively when they're not in the clinic, and then analyzing that data to look at things that could be an early sign of depression. There's a fair bit of data that's been built out around how cell phone use, the extent of use, the pattern of use could be and is significantly indicative of certain disorders. It is depression, even things that are very complex to diagnose, such as borderline personality disorders, there have been patterns of more texting from patients when they're sort of using borderline patient disorders, and those it's all about patterns. However, would I use that as a way of diagnosing it on its own? I would say it's more of a screener and an indication rather than something that would be a direct diagnosis. I think we are still far from having the equivalent of a blood test or a biopsy, which can lead to a diagnosis early on. I mean, the other point worth noting there is, things such as dementia, which one might argue is not strictly psychiatry, but falls well within some of the area there, is there's very little treatment for these early patients that can be justified. And so you're sort of looking at what's the value in diagnosing very early dementia where the treatment available is minimal, despite some disease modifiers coming through. I think the value question remains out there when you sort of start applying broad screeners across populations.
Mm-hmm. So Johan, when I get to a little bit more of some of these broad screeners considerations, every year I go for my annual checkup, and one of the measures is every year is an A1C, just to see if I'm on that pre-diabetic or diabetic continuum. Obviously very quantifiable. Are there quantifiable types of biomarkers that you think can be leveraged for mental health, whether it be depression, schizophrenia, PTSD, or others?
Yeah, well, not really today, of course. But I think you're touching upon something that is really very important, and that is the willingness to be diagnosed as well. And we just heard about dementia and early dementia. I have a little bit of history working on those disease-modifying drugs. Was part of the lecanemab program. That is actually one of the few or the only disease-modifying treatment approved for Alzheimer's disease. That is a treatment for early Alzheimer's disease. No one is stepping forward saying that I have some cognitive impairment. There are no neurology. The background is basically GP at best who is concerned about this. Does this GP have any test for cognition? No, normally not. There are tests, but they don't use them. They don't even like to suggest to use those tests on patients, even if they're skilled in using them. And they require quite a bit of training to be used. Even if you have a computerized test, it's not like a blood draw. So they're a little complex, and there are a lot of stigmas around diagnosing. So quite frankly, many people are not asking for being tested, and very few GPs dare to ask if they should test for it. And that, I think, will apply to whatever we may have for other symptoms in the psychiatric spectrum. There are certain diseases where we just don't want to be diagnosed. And if you compare to, say, oncology, cancer, I mean, most people would love to be diagnosed early because they really know that that's the way to stop the cancer from becoming dangerous. That is not happening in psychiatry at all, and actually many parts of neurology, particularly where you have more mental capacity decline. So this is a bigger problem than just having a test. Now, in neurology, there are ideas about blood tests, and even for what I mentioned here, Alzheimer's disease, blood biomarkers may come. They're already on the market, but not for diagnosis really, but you can play around with them. But that again requires a little bit of skill to be used. There are probably more advanced tests, computerized tests you can do for many of these conditions, but they are not validated sufficiently. And that takes a very, very long time. But there are a lot of interest in this. So I think a combination of a functional test and some digital test probably will come there in the future. But going back to where I started, I think it's going to still be a problem to have people wanting to be tested. So here we have a massive need for education. Destigmatizing is really super important.
And just to build on that, I think there's some very important points made, and the thing that it always stands out in psychiatry compared to things that are like oncology is the extent to which scales are used in clinical trials as a way of showing or not showing progress rather than something that is a single clinical endpoint. And these scales are complex mix of symptoms. They are validated by regulators, and they're used because regulators accept them. They are more often than not, they have very little to do with what actually happens in the clinic. And so the disconnect between what drugs claim they could do and what clinicians actually see in the clinic is, a bit far apart. And then it depends on how can you, to Johan's point, get clinicians to do things that are meaningful for patients, and then take them to a place where the drugs actually making a difference and bridging that gap with the average practitioner.
So to that, sorry, Johan.
I just wanted to fill in one thing, because I think Sahil said something very important. Psychiatry and neurology is a very strange division of the territory, right? We have psychiatric problems, massive ones in neurology diseases, and who knows, maybe most of the diseases, the good old saying is, when we understand the disease, it becomes neurology and it's not psychiatry anymore. Maybe that's true, right? We have some developmental disorders that were a little hard to classify back in the days, that we now know are monogenetic diseases, really, with clear developmental disturbances, right? There are many of those examples where we thought, strange behavior in children were just psychiatry, if I may put it that way. And now we know that's hardwired biology going on there. So there are fields where we're really sort of transforming psychiatry into neurology, but also bringing psychiatry into neurology is going to be a bigger thing. You will see more psychiatry drugs making use or becoming useful in neurological conditions. And we have a very popular field right now where I'm active myself, and Otsuka is active, and other companies are active, is agitation and aggressive behavior in dementia.
Mm-hmm.
That is kind of psychiatry. It's not neurology. It's a very, if you like, right? And you will see also other drugs. And of course, we have pimavanserin already for psychosis in Parkinson. So you will see more of those psychiatry drugs, or whatever you like to call them, moving into neurology and doing good.
Mm-hmm.
We shouldn't forget that. And we have more precision, although I just talked about the unwillingness to get diagnosed. We have much better possibilities to diagnose those diseases. I think just the neurologists need to be better trained in psychiatry.
So you touched upon something, and I want to get back to the heterogeneous nature of these diseases. When someone says depression, everyone says you're depressed. You can get an SSRI. Everyone knows the big SSRIs and SNRIs. Is a patient with a neurological disease, i.e. a patient with Alzheimer's or depression, are they different enough than a patient with, say, epilepsy and depression? And do they require unique treatments from their biological perspective? And is that a path forward in precision medicine for psychiatry?
Oh, wow. I wish I had some kind of intelligent answer to that, but I don't. And we have been struggling with this for years, right? If you have such a broad and undefined phenotypic symptom as depression, I mean, it's no wonder you have it if you start to be concerned about your cognitive ability. If you realize that you have multiple sclerosis going on or whatever it is, right? Is that the same depression as what we call MDD, major depressive disorder? I quite frankly don't know.
Mm-hmm.
There are probably similar parts of the brain involved, and probably some traits that are very similar. Something in the amygdala going around, right? You mull it over, and you can't get out of those negative thinkings. But is it the same disease? No, it's a symptom. It's a phenotypic symptom, right?
Mm-hmm.
So should we expect, say, SSRIs, just to take something very commonly used, to work across the board? No, we shouldn't. It's actually quite remarkable that it does work okay-ish across the board as it does.
Mm-hmm. Sahil, I don't know if you have any additional perspectives on that, thinking about treating the symptoms of diseases as unique precision medicine perspectives.
I think it's I find this quite, funny, because when you're sort of training to be a clinician, you're used to abdominal pain as a symptom and a range of differential diagnoses. You got, blood and urine. You've got a range of differential diagnosis. Sure, you can treat blood and urine, but you would make sure you treat the underlying cause, or for pain in abdomen. But depression's a symptom, and you rarely think of it as differential diagnosis of depression. Rather, you're more likely than not, unless there's a really good basis for it, treat the depression. It's almost the equivalent of getting rid, using a painkiller when you've got pain in abdomen, rather than actually treating the basis. And that's the unfortunate place we've been. And for what it's worth, especially for things like psychosis or schizophrenia, which, for what it, tends to be the most common reason for psychosis, or most common diagnosis for psychosis. You've got the same mechanism that's been used. You block the dopaminergic pathways and sort of get there without necessarily, and none of us really understand the biological basis for disease. I think at some point we all need to start thinking of depression as the symptom, and rather than the disease. Hopefully that day comes soon, when we actually know what's going on in there.
So if I'm understanding correctly, even though it may be a symptom, you still feel that if you treat the underlying multiple sclerosis, if you treat the underlying epilepsy, you may treat the depression? Or do you think there may be paths forward for that? And what I'm going with that again is that, is it a symptom, or is it a different biological disease? A patient who has long-standing epilepsy and has had EEG changes that you see, again, thinking a little bit more of a definitive diagnostic, does that mean that that patient needs to be treated differently as a result?
And I would argue they're different, because let's think of four conditions, right? Let's think of multiple sclerosis. Let's think of postpartum depression. Let's think of long-standing epilepsy, as you suggest, and let's think of vanilla MDD, major depressive disorder. I would argue they all have different pathophysiology because it's happened as a result of a different cause. You can blunt the feeling of depression by the SSRIs, and that's what you can do. But at some level, at the right time, if it's not early and it's not created those circuits in the amygdala that keep spinning, and you deal with the underlying cause, there should be a reason that you can address it. But it's then a longer conversation for each of these causes as to when and if you can treat the cause enough that it's less likely to lead to depressive symptoms. But it's as I said, it's a longer conversation, and there's a lot of other people who can speak at it longer than I can.
Yeah. So to that point, within the past couple of months, there have been two big M&A deals: BMS acquiring Karuna and AbbVie acquiring Cerevel, at relatively big premiums. I think it was 73% and 53% respectively. They are unique approaches, I guess you can argue, for schizophrenia and other mental disorders. So to the point of we treat schizophrenia the same, it's D2 blockade with some norepinephrine. We're seeing these novel approaches. What does that mean for the future of the industry? And are there ways to take these novel approaches to a bit more of a precision aspect?
Yeah, maybe I can have a go at it first. But
Sure.
First of all, are those mechanisms really novel? We can debate that.
Yes.
Xanomeline was a drug that was actually discovered by, believe it or not, Novo Nordisk, 1992, in a collaboration in the labs here in Denmark, actually, in a collaboration with Lilly. And then it was taken into a couple of studies by Lilly, probably 15 years ago or so, in schizophrenia and Alzheimer, and they worked, but with quite bad side effects. So it was kind of engineered out through fixed dose combination blocking peripheral muscarinic receptors. In the meantime, the whole industry was hammering on those muscarinic receptors. I don't know how many companies I've been in trying to find a muscarinic selective something, M1 or M4 or both, or allosteric or orthosteric, all different versions. This is just very, very hard pharmacology, hard chemistries to start with, and hard pharmacology. And I think what Karuna did was going the simple way and the most obvious way that we should have thought about years back if we were smart enough to do it. And some people like Bill Potter and of course Stephen Paul and those people did think about it. They came out of that Lilly effort, right? So they had time to think about it. I'm not necessarily believing that every M4 allosteric agonist we have out there would work as well as an orthosteric dirty drug that is taking care of its problems, right? So it's a hard one to say. Is this a new mechanism? Not really. It's been popular for years. Same thing with 5-HT2A agonists, right? The magic mushroom, psilocybin, has really got us back to that mechanism. And we kind of been playing with it for a long, long time. We can go back to Timothy Leary and LSD, right? The days, right? It does work. It absolutely works. I'm convinced it works. It's just that we haven't delivered well on it until maybe today. Mm-hmm. So is that true innovation? Yeah, it is, because we finally can handle it, but we are not dealing with new biology, really. We have sort of known about this for a very long time.
Mm-hmm. So, Sahil, I'd love to hear your perspective on that too, but is that the first step? We take the known biology, at least advance the therapeutics, and from there start to triangulate patient populations. Is a muscarinic agonist M4 better for a patient with, again, longstanding MDD, or is it better for a psychotic patient with MDT phenotype versus a schizophrenia patient without MDD? Are those the ways to move that forward? And are those the ways you think the industry will be moving forward as we're finally starting to see a little bit more investment within mental health specifically?
I mean, I look at this slightly differently. I see this as, if you take a step back and go 5 years before, so 2019, 18, 19, the industry was in a very different place on the level of, number of players who were interested in psychiatry. Most large companies had exited, were exiting very actively, right from Pfizer to Lilly to whoever else was involved. No one wanted to touch it. Very few companies, Johan's and mine, my previous employer included, were the few people still playing there. What's happened is large pharma company would want to, and you guys know this well, would want to play in a space and can justify early investments, capability build, if there's a de-risk later stage asset that justifies doing it. You wouldn't want to do it. And what the muscarinic progression in a relatively non-novel way, as was outlined, has allowed to do is invest in a class that is commercially novel, so has a certain commercial number attached to it, but is clinically de-risked enough? Is it later enough stage? Because Cerebral's writing the coattails of Karuna, realistically, and they've done it a couple of times. So what this has allowed for both BMS and AbbVie to do is justify building a new vertical and getting back into psychiatry in a way that is commercially de-risk because it's a novel mechanism, and so you can have the prices and assume certain projections. Clinically de-risk because it's the same class and one of the two has progressed further on. And I would think that allows them to make significant further earlier stage investments into novel mechanisms that are coming through, and then you can talk about where that could go. Highly likely to go down the precision route, highly likely to go down which is where a lot of the innovation and novelty I think lies. As old as it is, still untapped, the 5-HT2A route, the psychedelics, and there's potential path, not for everyone, but for some of these companies to go there. And I think that's what this has done. This has put capital back into the neuropsychiatry ecosystem and got earlier stage investors to invest in it. And this has more to do with needing a revenue stream with a patent cliff coming up, with a de-risked asset, a new vertical, and a projection for investors and shareholders, rather than necessarily wanting clinical innovation and being part of it. Because I agree, I don't think this is truly novel clinical mechanisms.
So, sorry, Johan, you're about to say something?
No, we seem to agree very much here. So, but there is one aspect here that I think is really very important. And you talk about this renewed interest in neuroscience and particularly psychiatry. And yeah, it's great to see some people jumping on something that used to be something no one wanted to touch for a while, right? If you look at, and I've done some lecturing on this because I get a little irritated when people say psychiatry is hard and not, neuroscience is hard. If you look at the last 8 years with FDA, top 3 categories of approved drugs include neuroscience. Yeah, that's not much psychiatry, admittedly. It's mostly neurology and it's gene therapy for childhood disease, whatever. It's a lot of a mixed bag of things. But neuroscience has actually been pretty good in delivering new drugs. And if you look at the amount of money that goes into neuroscience versus, say, oncology, it's a fraction. So productivity is quite high in neuroscience. Have those drugs been super duper blockbusters? Nah, not really. But GLP-1, weight loss, is a brain mechanism.
Yeah.
We tend to forget that, I talked about Novo leaving in neuroscience in the early 90s, right? They are big time back in neuroscience. And everyone wants to have a GLP-1 drug. Is weight loss a psychiatric disease or a neurological disease or a metabolic disease? We can actually debate that.
Or a combination of all. And to that point about GLP-1s, they're in Alzheimer's, Parkinson's, even things such as addiction. So to your point about broader biological mechanisms and understanding what drives these diseases, I think it gets to the point of, again, quite heterogeneous, multiple causes. And as we're seeing a lot of the big pharmas starting to come back into neuroscience and with mental health specifically, what are ways for them to become more productive? What tools? Is it tools such as AI? Is it tools such as real-world evidence? Is it a combination of all? What are ways that we can see moving that continuum forward to have, one, better understanding the science, and two, better diagnostics and better therapeutics?
So I think, let's look at it multiple ways. The first is, can AI help? I think the place at the moment, there's 2 or 3 ways in which artificial intelligence and whatever you imply that means in this situation means. Drug discovery, I think let's accept that most psychiatry drugs available today are very dirty. They are not clean drugs. If you can use artificial intelligence and basically machine learning to have those bind in a much cleaner way to receptors and clean up those profiles, the chemistry and hence the pharmacology specifically, I think that could be a significant step forward. And the next piece is clinical development, and this is Johan's shop, but I would think definitely better patient selection, segmentation, making sure that you understand where the drug is seeing an effect better in early trials to better define those populations and de-risk them, make them smaller to have a better effect. There's a lot there, and that's the holy grail of for me the holy grail of precision medicine and psychiatry. If you can pick a range of 4 or 5 things that you've understood about the patients, but then for me that comes down to, will you for a new drug know enough about it by the time you reach phase 2 or phase 3 development to specifically define a population? That's tough unless you find a new biomarker that leads to that. And for me, the central piece there is real world evidence. There is a lot of behavioral health data out there now, a combination of electronic health records and then overlaying that with claims and seeing what patients have seen what effect. And if you can use that to better build a combination of using that to recruit patients and identify the right patients, but then synthetic arms and other things which sort of enhance your clinical package to a place that you don't need these effectively $1 billion bill to get a drug to the market. It could potentially transform drug development, but every company is trying it in different ways. There's no one, I don't think anyone's gotten there yet, but that's my view. I think it's the entire thing, and obviously it'll have implications on commercialization because those patients will get the drugs rather than everyone.
So Varun, if I may add one thing here, as sort of, Sahil, I'm sure you know a lot about drug development, so I'm not. I think you understand this quite well. But let me add sort of a component of drug development I think people really have to get right, and that is to do early drug development properly, phase 1 and phase 2. And for some reason, particularly in psychiatry, we've been very eager to go from phase 2, the proof of concept trial we do or whatever, to phase 3. And if you look at the 2 crown jewels of drug development, is to show that a new mechanism, if that's what you're studying, works in patients. That's a rare event. It doesn't happen often. We spend years and years and years trying to find new drugs, and many people go through a whole career in R&D and never be part of that directly. So that's a really, really big thing. The second big thing is finding the right dose. And psychiatry is also about dose titration often. And that is something we often do quite sloppily. I still think we should spend much more time in phase 2 with just better designs. And there are base and adaptive trial designs, that there are many, many innovative ways to do this. That doesn't necessarily implies that you have a great biomarker or stratification tools. You just use the trial design to dial in to the patients you're after, and also finding the right dose or dose range you need to use. And that, I think, would fundamentally also change how you move forward into phase 3. If you see some of the more spectacular phase 3 failures that we've even seen last couple of months, to be honest, it's because people, I think, have been a little impatient and rushing to phase 3 too quick.
So I'm going to draw the parallel to oncology because that is where we've seen the most precision aspects. And I'll draw on a broad cancer. Let's say it's lung cancer. I'm looking as the early days of lung cancer where we gave, for lack of better words, the dirty drug, chemotherapy. It had side effects, it had titration issues, and that was often the reason patients stopped treatments. And then certainly patients would progress beyond the chemotherapy. I feel like that's where we are in neuropsychiatry. It's that the treatments we have now are probably more akin to that chemotherapy, and we're moving forward to more precision aspects. And here, obviously, a lot of nuances because there's, to your point, dose titrations here a little bit more. There's phenotypic considerations. It's not strict. Getting back to melanoma, BRAF, or lung cancer, KRAS. This is a lot more nuanced, but I'm seeing a lot of those parallels. And there's something that both of you touched upon that is really intriguing me right now. And that's, again, these are dirty drugs, patient have side effects. We've heard all about weight gain with some of the atypical antipsychotics, sexual dysfunction with SSRIs. Even if we don't want to move forward into the new therapies, if we can maximize the current therapies we have, using AI rolled evidence, there's a ways of determining patients who may be prone to developing potential side effects so they can at least maintain their therapy longer. And is that also a path forward in precision psychiatry?
Yeah, I mean, obviously, that is a pathway forward. Do we have the technical and scientific background to do it? To some degree, yes, I think.
Mm-hmm.
And that goes back to what we talked about before. You need to turn what we measure into more objective things. And I think that's where digital comes in big time. Sexual dysfunction, you can measure in many different ways. You can ask someone, and sometimes people like to talk about it. Sometimes they don't even like to talk about it, right? Or you can actually maybe in the future have an actual device that measures this, right? It may be intruding in privacy, but there are ways to measure these things much more objectively, right? And it could be hobbies, whatever you have, right? So there are ways to move forward, but they will not be traditional oncology, biology based. It will be other things. And maybe we have miniature measures in the future that can tell us something, or I don't know, amygdala circuitry speed or something. I'm just making it up because we're still struggling with these things, right? But there is something to that. There are pathways that we like to influence, and we're getting better and better influencing those pathways.
Yeah, I mean, Johan said it, right? I think analogies make conversations interesting, and so it's good to have them with oncology. But I personally don't think this is going to progress down the same path where that was primarily based on better understanding the biological basis of disease, and this I would think more likely to follow down better understanding sort of segments of patients segmented differently rather than a broad single symptom driving it, and understanding aspects of the presentation of the disease that is meaningful of or linked to a certain potential biological pathway, which I would argue, at least for the next decade, I haven't seen anything that makes me feel like we are on a path to have that as the basis of drug development.
So to that point, and maybe the last topic here, something we've all lived through the last 3-4 years, and it's still waxing and waning, but COVID. And a couple of perspectives I'm thinking about here is that I think people realize now that depression is more serious than people said. To your point, Johan, people don't want to talk about it. I'm seeing more conversations about mental health in the post-COVID world. What does that mean for the development moving forward? And do we, again, getting to different diseases, do we treat COVID depression different than regular depression? Do we treat COVID PTSD different than other PTSDs?
Wow, it's a tough one because it comes with many facets. Number one, what is post-COVID syndrome? Yes, there's definitely something that looks like it. I have a friend, neurologist, who was frontline doctor in Italy when in Milan area, when they had all these things. She doesn't believe in post-COVID, and we have a big healthy debate about it. She just thinks it's another version of chronic fatigue syndrome or whatever we like to call it, right? But so there's a lot of struggles here, right, to recognize and diagnose and what is going on in the brain. Some is definitely neurology, and we know for sure lack of anosmia or whatever, we have clearly neurological symptoms, right? There's something going on, and it's actually easier for people to talk about it. It's kind of a little bit like you talk about your, ski injury you had or something. It's almost a little bit, it's good.
Stigmatized.
And it's okay to talk about, because I had a virus infection, so that's why I can talk about it, right? It's really interesting. People talk about post-COVID syndrome much more than they talk about their MDD, major depressive disorder, right? It's kind of okay for some reason, because it's kind of a biological reason behind it. Yeah, it's an interesting aspect, but I think we are lacking a lot of precision and understanding what it is. We were involved on the roadside, I have to say. It was an investigator-initiated trial with one of our antidepressants in post-COVID syndrome, a drug that actually had lots going for it. It's also a little pro-cognitive, etc. So we thought that was a good idea to test it. Didn't really pan out particularly well. So here, if there is a true depression in post-COVID, for example, or cognitive deficit, then the biological differences were not helping us here. They were probably too big for that drug to work.
So at the very least, in Sahil, would love to get your perspectives on this. At least a lot of what we've been discussing today is there's still stigma. At least maybe in the post-COVID world, people are willing to talk, hey, I have these symptoms. As people talk more, does that give you an optimistic future for developing mental health therapies? And as patients talk more, do we retrain psychiatrists? Do we retrain PCPs to test more often, to treat differently? And does that give you more optimistic perspective for mental health treatments in the future?
So, I mean, I think you've hit the nail on the head. I was about to make a comment about the stigma piece that came up, right? I mean, reality is it's in a way funny, because what people are saying is, it's okay to have depression because it's not come from me. It's come from that virus. It's not me. And it's handing over the accountability to something else to cause that problem in your mind. And it's sad at the same time. And I think reality is there's been a significant progress with stigma. It's different in different countries, different parts of the world, different cultures. I can say it's definitely more progressed in Europe compared to the United States, having lived in both places over the last years. If we have to make progress, having objectivity on diagnosis, tests which are more specific, rather than a psychiatric having a sort of a human conversation which is more linked to the patient and why it's happening, I think will help. I think patients, the equivalent of a blood test giving a report and then having a treatment which is linked to that will make significant progress. So anything that can make it more precise, that can make it more related to a battery of tests or whatever it is going to look like, will make it better. And ultimately, side effects profiles haven't been great. So I think we are on the right track. But there's a lot of work. I feel good about more large players entering the space, because what this also needs ultimately is resource, policy work, and all of it, which is hard to do when there's not enough momentum behind it. So I would agree. I think I feel optimistic. I think things are going in the right direction, and there's hope. Yes.
Yeah, Johan, same question to you. As we see and thinking about our whole discussion today, how do you feel about the future of mental health treatments? Are you also optimistic and understanding a lot of work in terms of not just biomarkers, blood tests, phenotypic considerations, developing better qualitative and quantitative tests? Are you optimistic moving forward?
I'm absolutely optimistic, but it requires that we have that discipline I talked about. When it comes to drug development, don't repeat old mistakes, learn from them, do it right this time. Don't rush into phase 3 and get all those high-profiled failures, right? Do things right and work on the mechanism. We actually understand quite a bit, because they are about to be delivering now, finally, some of those mechanisms that we've been working on for a long time. Great value as it looks. So I have to be optimistic. And there are new ways of treating even depression, more acute sort of ways. The whole psychedelic space is super interesting, complex, but super interesting. And these things are working. We just have to figure out how to deliver it.
All right. Wonderful. I just want to take a step back and say that early days, it's going to require a lot of resources, a lot of education, better disease understanding, better patient segmenting, but there's a clear path forward, and excited to see all the money coming back into the space, the deal activity coming into the space, and the greater acceptance from society about mental health and talking about it, getting diagnosed and treated. We're early days, but I think conversations like this, more discussions about these kinds of topics, will hopefully further the cause, and really excited about seeing how we develop and give better treatments to our patients moving forward. So with that, just wanted to really thank both of you. This has been a fantastic discussion. I'm sure we could have gone on another 10 hours easily, but this is just wonderful, and just wanted to really thank you both.
Thank you.
Thank you.
Thanks for the invitation. Yeah.